And thanks everybody for joining. I see over 120 folks on the line, and I received probably as many emails in preparation for this because Jamie Weaver was an important member of our community and had a huge impact on so many of us. So we lost Jamie Weaver last month at the age of 44. Jamie had Jamie's family and friends were able to gather for a celebration of life last week in Toronto, and it was while it was a very challenging and sad time to mourn our loss, it was also a wonderful time to celebrate a remarkable life and a remarkable individual. And I had the great opportunity to enjoy meeting many of Jamie's friends and learn about the part of Jamie's life outside of our OHDSI community, and to share briefly some of the work that he had contributed and the impact he's had on all of us as part of his work and scientific family. But one thing that I feel very strongly about is Jamie, for all of his excellence as an individual and as a friend, as a colleague, he also prided himself on tremendous science. And so today we're gonna focus on celebrating the science of Jamie Weaver, talk about the work that he did and the impact that he had. I plan to talk for about 15 minutes just to highlight some stories from the scientific work that Jamie did. We will replay Jamie's 2021 closing talk that had a profound impact on so many of us in the community. And then I will be opening it up for those that want to share reflections about working with Jamie in our community, and look forward to for those who feel comfortable sharing. So Jamie joined my team at J&J about 10 years ago and instantly became one of our most active and fervent leaders in our OHDSI community. Many of you know of him because he was your faculty lead in our estimation tutorials. Many of you are aware that he was one of our earliest Titan Award winners for clinical applications. Those of you who participated in OHDSI study-a-thons may remember Jamie from being the stalwart, both behind the scenes and in the front of the stage doing that. And any of you who've conducted an OHDSI network study have probably engaged with and gotten help from Jamie in running network studies. You know, it's often the case in our community that I say that, you know, we're doing something very complex, you know, to advance our mission to generate evidence that can improve patient care. It's not something that any one person or that can do by themselves, because it requires a multidisciplinary approach to evidence generation. It requires expertise in data standards and methodologic research and open source development and clinical applications. And I always say that there's not really any of us that can do that alone. And while Jamie lived his life and lived his professional life very much adhering to the mission, say that he was one of the unicorns that actually did demonstrate excellence in data standards, methods research, open source development, and clinical applications, and impacted our scientific development as a community pretty substantially over the last 9 years that he was an active leader in our community. And so I think it's fitting that we pay tribute to the scientific contributions that Jamie made as a starting point, because I know that he would have appreciated making sure that everybody knew giving a Jamie flex to all of the great work that he led for our community. And so while he did publish over 25 papers in our community on various topics as a co-author, I'm going to highlight 6 publications and stories around 6 papers that I think are a fitting overall summary to the work that Jamie has contributed to and the impact that he's had. And so I'll take a few minutes to if you'll indulge me, to go through a very biased story of the impact that Jamie's had. The first paper I want to highlight was published in Lancet Rheumatology. This was titled Opioid Use, Postoperative Complications in Implant Survival After Unicompartmental versus Total Knee Replacement, a population-based network study. And Jamie co-led this study with Ed Byrne, and this was a study that came out of our Oxford Study-a-thon. It was actually one of the studies that was the basis for Jamie earning that Titan Award in 2019. Now, this paper was an opportunity for us to conduct a network study to do population level estimation, and I'll share the abstract here briefly. The part of the motivation for this study was that there had been a randomized trial called TopCat that had generated evidence about the comparative safety and effectiveness of these two different surgical interventions for knee replacement. However, there was very open questions about the durability of that evidence. And so together we conducted a network study to study patients who required knee replacement surgery and looked at outcomes following whether somebody received a total knee replacement or a partial knee replacement, and looked for both short-term and kind of longer-term outcomes associated with this. Together, we were able to put together an estimation analysis and run a network study that comprised hundreds of thousands of individuals across multiple databases in the US and the UK. And ultimately, in this study, we identified that unicompartmental knee replacement was associated with a reduced risk of postoperative opioid use compared to total knee replacement, and also showed that it had a lower risk of venous thromboembolism. However, the partial knee replacement had an increased risk of revision. These results were actually published and shared as kind of corroborating evidence to the entire orthopedic field, and I think has, based on the citations, has had a meaningful impact to complement the evidence base that was there. And I know colleagues from this study-a-thon are on and can share reflections at the end of this call. Now, one of the things I want to highlight is that Jamie very much was instrumental in driving this study, both in terms of helping guide our Oxford Study-a-thon group into the design of the study, but very much driving the implementation and execution. I'm highlighting here this forest plot that shows the results across 5 different databases that we ran the analysis and 6 different outcomes in this plot showing these meta-analysis results, which was for the first time a network study that actually examined these effects. And it was necessary for us to achieve the statistical power for us to reach these conclusions that a single database study or a single randomized trial was going to be largely probably insufficient to be able to show. And this was a good example of the power of a network to show consistent, reproducible results across multiple databases, and the value of actually bringing different databases together. And I remember Jamie being very motivated and excited, despite the fact that way back here in 2018, when we did this, those of you who are currently struggling with the OHDSI tools can only imagine how primitive we were back then in terms of running tools. But Jamie was so adept at cobbling things together to make a network study, be able to execute across multiple databases and multiple partners, that it made it possible to generate this result. The story I specifically want to share about this study was, I remember, and I know Danny's on and he'll remember parts of the stories too, but I remember Anthony Senna and Jamie and I staying up very late during that study-a-thon to make sure that we were prepared for the next day so we could give the group the results. But as soon as we published this paper, there was a letter to the editor responded by Frank DeVries, who said, "Is there a need for review-a-thons?" And I will just read very briefly this paragraph where he basically challenges the premise of what we pulled off. And he specifically says, "Is it possible that within 5 days, approximately 300 pages of study documentation, a study protocol comprised of 259 pages, a published paper, 30 pages of appendices, and numerous pages of R syntaxes were actually created?" And indeed, this letter to the editor basically says, like, I don't actually believe the hype of the Eden Project and this whole notion of a study-thon, because it can't be possible that researchers can come together and do all of this work in a short time. And so Jamie worked together with Danny and Ed and myself to provide a reply to this email. But I very much enjoyed when we got to write the statement. "We would like to reassure the readers that the vast majority of the study was indeed done within a 5-day study-a-thon, where we brought together individuals with knowledge of the data sources used, methodologic approaches used, and clinical area of interest. And during this week, the study was designed, the analysis were run across the data source, and the results were then considered and interpreted." What I think we left out of this statement was this was only possible if Jamie Weaver was there. His work in supporting the community to make this possible truly did make it possible to do the impossible in 5 days. And I as much as generally when we get a letter in response to one of our papers, I get concerned about the criticism. In this case, the criticism that it seemed incredible, meaning lacking credibility, was a beautiful testament to the remarkable science that Jamie Weaver has delivered in our community. Next paper I'd like to highlight was published in Lancet Rheumatology. It's entitled Risk of Hydroxychloroquine Alone and in Combination with Azithromycin in the Treatment of Rheumatoid Arthritis, a Multinational Retrospective Study. And this study was co-led with Jenny Lane and had many members of our community as part of this. This was a study that actually came out of our COVID study-a-thon, where at the early stages of the pandemic, there was tremendous concerns about potential treatments for COVID. And in the absence of vaccines, people were kind of looking for anything, whether it be antibiotics, anti-malarials, steroids, whatever it could to help mitigate the challenges that COVID was introducing to patient populations around the world. And one of those treatments that was being speculated as a candidate therapy was hydroxychloroquine. And yet, when we looked at the literature, there was actually relatively limited information about hydroxychloroquine in both the short and long-term safety of this drug, which has been previously indicated for and approved for use in rheumatoid arthritis and for rheumatoid arthritis. In this study, because we already had large data sets comprised of patients with rheumatoid arthritis, we could actually examine the safety of hydroxychloroquine. And we conducted a very large network study to examine the risks associated with hydroxychloroquine, both a wide battery of adverse events, potential adverse events. And we conducted multiple analyses, both comparative cohort designs and self-controlled case series, to investigate this data across 14 different databases around the world. And while this study indeed is published in Lancet Rheumatology and is describing the effects in a rheumatoid arthritis population, that's because this was the only way that at the very start of the pandemic, when there wasn't really much data about patients with COVID, this was the only way that we could generate robust evidence to inform the COVID pandemic and to inform the appropriate or potentially inappropriate use of hydroxychloroquine in the context of COVID. So we conducted this study, which had nearly 1 million patients of hydroxychloroquine, conducted this analysis, and actually our study revealed that there was an increased risk associated with hydroxychloroquine in long-term use for cardiovascular mortality. But also we observed that in combination with azithromycin, the combination of hydroxychloroquine and azithromycin increased the risk of cardiovascular mortality, chest pain, and heart failure. And so we were both able to provide reassurance information about many adverse events. The short-term effects did not appear to be substantial, but this specific unique combination was something that we did observe an increased risk. That information was particularly relevant given in COVID, people were taking these combinations of antibiotics and hydroxychloroquine. Now, what I want to highlight is just the diligence of the work that Jamie led. Jenny did a wonderful job co-leading this work with Jamie, but Jamie was really the driving force behind all of the statistical analyses and the network study that we ran. We generated extremely thorough investigations looking at hydroxychloroquine versus sulfasalazine for a wide battery of outcomes using multiple time at risks, generating reams of evidence that is not what you'd commonly see in any sort of study. But this also allowed us, by having a rich network of databases around the world, for us to be able to reveal associations that would not be identified if we only had one database or a couple databases. In particular, by having data around in our partnership with the VA and having access to U.S. claims and EHR data, we were able to achieve statistical significance to observe this increased risk associated with cardiovascular mortality, chest pain, and heart failure. And while some of these effect sizes were pretty small, these are pretty substantial effects, very serious effects. And in the absence of any evidence suggesting hydroxychloroquine actually worked to prevent the issues associated with COVID, pretty substantially changing the benefit-risk profile of the use of these treatments. It was actually this study that Jamie co-led that resulted in the European Medicines Agency issuing a reminder about the risks of hydroxychloroquine to all medical providers in Europe. This announcement that they made in April of 2020 specifically highlighted that recent studies have shown serious and in some cases fatal problems with the use of hydroxychloroquine, and they cited two papers, one of them being our Odyssey study that was co-led by Jamie as the evidence to actually impact clinical care. This study, I think, directly changed practice, as we observed subsequently that the use of hydroxychloroquine substantially dropped, and it's not too hard to actually calculate the number of lives that were saved on the results of this study having a direct impact around the world. And I think it was a great testament. What I'll also highlight was, from a methodologic point that Jamie was particularly proud of, this risk communication came out in April 2020. If I go back to this study, this paper was actually published well after that date, and that's because Jamie was very committed to the idea of open transparency. This paper was posted on medRxiv well before its initial publication, and that evidence got in the hands of decision makers as quickly as possible and as thoroughly as possible to make it possible for the EMA to make informed decisions to guide clinical practice. One of the other things that came out of this was the next study, which was published in Rheumatology, and it was titled Risk of Depression, Suicide, and Psychosis with Hydroxychloroquine Treatment for Rheumatoid Arthritis. And again, Jenny and Jamie co-led this study together. Why I highlight this is because in the concerns associated with hydroxychloroquine, the EMA received a series of spontaneous adverse event reports that raised the potential concern about depression and suicide, which would have been further adverse events that we didn't previously study in our first study, but if those were to be true, would have certainly changed the benefit-risk calculus in thinking about the use of this treatment. And so because the EMA had partnered with us in our initial study, they asked the question, can you guys go ahead and add additional outcomes to your study and then provide us information to inform our regulatory decision-making? And I remember when Danny shared this news to Jamie, and Jamie was delighted because he was excited about the opportunity to have direct translatable impact. So many times we do research and we publish a paper, we hope somebody reads it and it might make a difference. But in this case, we knew that the study that we were going to execute was going to have a direct translation into patient care. And I remember Jamie being very motivated to get this study done extraordinarily quickly. So this study actually found that hydroxychloroquine did not appear to increase the risk associated with these other outcomes that the EMA was initially concerned on. And on the basis of this became something that wasn't central to the benefit risk calculus, but that reassurance that we could provide from this study was a testament to his focus on making sure that we do high quality science that we can trust. And what was remarkable about this was that same diligence, even though we needed to conduct this study in a matter of a couple weeks, where a study like this normally would take over a year, Jamie never cut any corners in terms of the diligence that we applied to apply all of Odyssey's best practices at the time, to generate results across a large collection of databases, and to produce pretty definitive evidence to support our regulatory decision-making. Switching up to a different paper and a different story, Jamie led a study that was for J&J. It was entitled Comparative Risk Assessment of Severe Uterine Bleeding Following Exposure to Direct Oral Anticoagulants, a network study across 4 observational databases in the U.S. This was published in Drug Safety in 2021, but it was specifically in response to our colleagues at the FDA, as part of the Sentinel network, posting that they were going to conduct a study on direct oral anticoagulants, of which rivaroxaban was one of those products that J&J is the marketer of. And so when it was communicated that Sentinel was going to do a study in the Sentinel network, it was very clear at J&J that we needed to conduct an analysis to make sure that we understood the safety of our product responsibly and quickly. And there's only one person that we could turn to in our group to think about how we were going to be able to compete with the fact that Sentinel was already doing their study, and that was clearly that Jamie had the technical and scientific fortitude to drive this study. And so Jamie led this study on behalf of J&J and published it. And the thing that I particularly appreciated was that we had some information about what Sentinel was going to do, but we also recognized that there was probably a lot more that could be done in terms of the thoroughness of the analyses and the breadth of the different comparisons that could be made. And Jamie was very committed to using this as a study that, while it was for J&J, was going to showcase OHDSI's best practices and show the totality of what's possible by using OHDSI's tools. In this study, we did indeed observe an increased risk associated with uterine bleeding for the direct oral anticoagulants, and provided head-to-head information that actually informed us internally at J&J about how to think about communicating this risk, but also, as Jamie was very proud of, we designed, executed, and delivered this results all before Sentinel ever reported out the results of their particular study. One of the things I want to highlight is that Jamie actually used this as an opportunity to showcase open transparency at the greatest level. Our table 1, showing how we compare baseline characteristics before and after matching, was a very robust summary. But as many of you know, in our OHDSI tools, we end up with hundreds or even tens of thousands of baseline covariates to explore. And rather than failing to disclose that, Jamie was very adamant that he was going to build a custom RShiny app that was going to show all of the results from all of his analysis. And he made that publicly available as part of this study. He also was one of the earliest adopters of many of our innovations in the OHDSI community, and in fact published calibrated hazard ratios. And I think this is one of the first studies that we actually had calibrated hazard ratios published, such that we had great confidence in the results. Another area that Jamie worked on that people may be less familiar with was investigating how to link mothers and child in U.S. claims databases. And he published this paper in BMC Medical Research Methodology, specifically to develop and evaluate an algorithm for linking mothers and child in multiple databases. This work was significant because Jamie was very concerned about the generalizability of the findings of our mother-child linkage. It's one thing to have data about mothers and data about children and being able to explore the relationships there, but it's another thing entirely to be able to actually quantify how does that mother-child linkage pair match up to those that couldn't be linked. And Jamie spent a lot of time really digging deep into making sure that when we created this algorithm, that the results would be broadly applicable to all mothers and infants that we may want to study as we consider the investigation of safety of medical products in maternal care. And one of the things I appreciated about this study was, in true OHDSI style, he thought about this problem at large scale and produced a bevy of evidence that was made publicly available, exploring both the market scan and ClinFormatics dataset, showing how the mothers that were linked, how they compared to the mothers that were not linked, and showing largely consistency before, during, and after their pregnancy, which really gave us tremendous confidence that this mother-child linkage is ready for our use for perinatal questions. And I'll highlight also, again, Jamie was really a true leader and an inspiration in terms of driving for full transparency. In this paper, he made available all of the source code, as well as this interactive web app that you can still go out to and play with today to explore these gigabytes of results to have a very thorough understanding of the effect. The last paper I'm going to highlight is a paper that was also published in BMC Medical Research Methodology just last year. This paper, entitled "The Necessity of Validity Diagnostics When Drawing Causal Conclusions from Observational Data, Lessons from a Multi-Database Evaluation, the Risk of Non-Infectious Uveitis Among Patients Exposed to Remicade." Now, this is a paper with only J&J authors, but what I want to really showcase here is this was Jamie being really probably the leading early adopter of our innovations in the community and bringing them to real questions. There was an open question about a product, Remicade, and its association with uveitis. But what Jamie was motivated was applying these latest innovations that Martijn and Mark had showcased at one of our OHDSI symposiums, the idea of the introduction of objective diagnostics to determine whether or not a network study could actually generate reliable evidence. And so in this study that Jamie led, the clinical question was very clear. Does Remicade increase the risk of uveitis? But the broader question that he was really motivated by was, how much can we trust this evidence? And because reliable evidence is really at the heart of what we're trying to do as a community, I think that this paper is a beautiful showcase of what's possible and how to be transparent when you actually don't have answers to questions. In this specific case, Jamie kind of did all of the OHDSI best practices at the time, inclusive of using phi-valuator to estimate the measurement error associated with his phenotype for uveitis. And then he summarized across all of these comparisons, across all the different indications, across all the different drugs, which of these analyses actually passed our diagnostics associated with covariate balance and equipoise and the use of negative controls to observe residual bias. And despite the fact that he ran literally hundreds of analyses, very few of them actually met this criteria of diagnostics acceptance and could be made available. And I think it's, even as a best practice in our community, it takes courage to actually say, we don't know. And not only did Jamie demonstrate that courage in this paper, but he actually really showcased why we need to produce all of this evidence to showcase when we believe observational studies are right and when we actually believe that the evidence still needs, that evidence is not sufficiently reliable to generate evidence that can actually inform our patient care. This was a paper that was published just last year, and it came hot off the presses of some of the innovations that we're doing in the community. So with those stories in mind, I'd like to transition, and Craig, I'll stop sharing here for a second. Jamie was a remarkable scientist in his own right, and all of the science that he did, just some of these examples demonstrate how he's really kind of an inspiring leader. Many of you also know that Jamie shared courageously his personal health story with us, including at the 2021 closing ceremony, where not only did he share with us his personal experience, but he also shared how he believed evidence was going to actually inform not just his life, but the lives of others. And so I'll let Jamie take it from here to replay that closing talk to further inspire all of us as we think about why we're here in the OHDSI community and what we can do to improve the lives of patients like Jamie.
Hi, I'm Jamie Weaver, and I'm an epidemiologist at Janssen R&D, and I've been an OHDSI collaborator for 6 years now, and I've worked with many of you. I'm an empiricist, and I believe that knowledge comes from observation and what you can infer from it. By systematically assessing sets of observations, we can draw inferences about the underlying data generating process that may be generalizable, and we casually call these inferences evidence, and we can use them to support all manner of application. I don't know how many of you get regularly tangled up in epistemology and philosophy of science, but I'm quite certain that all of us spend a considerable amount of time in the deep weeds of the scientific and technical processes of generating reliable evidence from healthcare observational data. While doing this, it's easy to forget that these empirical observations that we rely so heavily on are people, each one of them consisting of their perfectly unique set of experiences, characteristics, and qualities that define who they are. And I'm drawn to this type of research because I'm so captivated by this human diversity that's captured, however incompletely, in real-world data. But rather than speak about research and objectivity like usual, instead, I'm going to speak to you today about my being a patient and my subjective experience with cancer and how real-world evidence has really helped me with an important decision. I spent the summer of 2020 with gradually worsening back pain. Since it wasn't improving with physiotherapy, later that fall, my sports medicine doctor ordered an x-ray, both of us expecting to find muscle, ligament, or bone injury from my insistence that I can still play basketball like a teenager. But instead, the x-ray revealed several masses in my lungs. As quickly as she could, my doctor scheduled me a CT scan at the local cancer clinic, where they would be able to see me in 3 weeks. But being properly scared and very uncomfortable waiting this long, and with increasing back pain, I chose to present the next day at the emergency department at a hospital near where I live in downtown Toronto. So I explained my situation to the emergency room doc, who promptly ordered me a CT and MRI. Within a few hours, this doctor and the radiologist on call reported that I had extensive metastatic disease with lesions in my lungs, liver, pelvis, and spine. My back pain was from vertebral compression fractures and nerve compression, and I was extremely lucky that my spinal cord wasn't compressed. It was very close, and immediate surgery had been suggested until a larger team had reviewed my MRI. We thought it was melanoma, considering that I'd had a stage 1A mole removed back in 2017. My sentinel node biopsy was negative, and in retrospect, I was terribly overconfident in that result. I suppose I shouldn't have been surprised by this new diagnosis, given my history and knowing that diagnostic tests regularly return false negatives, but I was still shocked. So that day, the ED doc made my referral to Princess Margaret Cancer Center, also in Toronto. It turned out I could be seen and assessed in a week, so I went home with some painkillers. During that week, between my ED visit and my appointment at Princess Margaret, my health deteriorated considerably. The pain in my back was steadily increasing. It was now radiating elsewhere, and I was unable to sleep. It was quickly becoming totally unbearable. So when I got to my appointment at Princess Margaret, they took one look at me and immediately checked me in, and I stayed for a week. I was stabilized, got my pain under control, and had more imaging done and a biopsy and molecular test that indeed confirmed BRAF mutation positive melanoma. I got to know my medical oncologist a little bit, and we discussed his recommended treatment strategy at length. In collaboration with the radiation and surgical oncology teams, we first ruled out surgery and then decided on a course of radiation for my spine. Lastly, and based on the evidence from an ongoing trial comparing the sequential combinations of targeted therapy and immunotherapies for melanoma, I initiated dabrafenib trametinib targeted therapy for 8 weeks and would then switch to ipilimumab nivolumab, or ipi-nivo, which are both immunomodulating monoclonal antibodies. I've spent a great deal of time considering inclusion and exclusion criteria in trials and observational studies, but this was certainly the first time that I was reviewing these criteria to assess whether I met them. The question was really, how much does evidence from this trial actually apply to me? These treatments got underway in early November. The targeted therapy ended up lasting about 10 weeks because of a few breaks needed for fever to pass, which is a known side effect. I was fatigued and was with too little energy to really effectively participate in my family, social, or professional life. I relied on others more than I ever had, and I felt extremely sad for my kids. It was really not a great time. Before switching treatments, my care team recommended another round of radiation for my spine in case the time from immunotherapy initiation to its beneficial effect took a little while. So we did this, and then it was mid-February by the time I started combination ipi-nivo immunotherapy. It got off to a rocky start. I pretty quickly developed pneumonitis, and it was unclear if this was attributable to radiation, immunotherapy, or both. Regardless, we treated this with steroids, which I took for 3 weeks and tapered to a low dose before resuming immunotherapy, this time Nivo monotherapy. Everything seemed okay and improving at this point until my MRI in early May that now showed brain metastases with bleeding. I had one 4-centimeter lesion on the right side, parieto-occipital region, and about 10 smaller lesions elsewhere. Almost immediately after getting this news, I began to experience the associated neurological deficit. At first, I was a little unsteady on my feet. I veered a little to the left when I walked. Then it became difficult to type with my left thumb on my phone, then with my entire hand on a keyboard. And eventually I started getting surprised with the presence of my left hand altogether because I was clearly failing to properly register where it was in space relative to the rest of me. On May 10th, I underwent a craniotomy procedure to resect the large tumor. This procedure was performed without complication, thankfully. Recovery was no fun, and it was made worse by the pandemic visitation rule of 1 visitor for a maximum of 3 hours per week. These hospitals are truly amazing places. They're the pinnacles of medical sciences, where major neurosurgical procedures like these are routine. But hospitals are not great places to heal. I was in some terribly dark places during my 9 days of recovery, and at times I was really tested with what I thought were the limits of what I could endure. It was also in this time that I received a huge outpouring of love through every electronic channel conceivable, which really helped me get through this. So I was slowly but steadily recovering from surgery, but by now I'd been off immunotherapy for almost 2 months, and my doctor was anxious for me to resume. This presented some tension. it was possible that the ipilimumab was working in that it had shrunk the tumor, but was also harmful in that it may have caused the bleeding and inflammation. Until this point, my doctor had supported every treatment decision he recommended with evidence-based rationale, and I'd actively participated in deciding which approach may offer a better benefit-risk profile. But unlike these previous decisions, evidence to support this next step was sparse. But it didn't matter because considering my disease progression, I had to continue therapy and I had to make a treatment choice immediately with substantial implications for me and everybody in my life. So the decision that I now faced, was whether to resume immunotherapy as combination ipi-nivo or nivo monotherapy. This represented a pretty clear benefit-risk trade-off, but there was uncertainty about the benefit with speculation that combo ipi-nivo might be better. But there was also uncertainty in the risk with the concern that combo ipi-nivo might increase the risk of more intralesional swelling or hemorrhage that would require neurosurgery to correct. I did know with certainty that I'd had neurosurgery already and did not want to go through it again. Evidence from landmark clinical trials has provided a really strong evidentiary basis for first-line immunotherapy in newly diagnosed melanoma patients. But since my clinical history was drastically unlike the patients in these trials, that trial evidence was really less applicable to me. So, as an epidemiologist at a large pharma company and member of the OHDSI community, I also have unique access to the tools and resources to rapidly create real-world evidence. So I decided to generate some to add an additional piece of information to support this decision. And of course, the indefatigable Patrick Ryan helped me. Okay, so here's what we did. Our initial goal was to try to find patients as similar to me as possible. So we entered my entire recent clinical history into an Atlas cohort. And this was a fun exercise, but we, of course, and as expected, we found 0 patients. But after much iteration, relaxing many restrictions and redoing concept sets, all the cohort building activities, we were able to eventually find patients that still looked somewhat like me. We landed on the following definition for the general population. This was males aged 30 to 50 years at first occurrence of stereotactic radiosurgery of the brain. And then we restricted them to those with metastatic melanoma anytime prior, brain metastases in the last year, and a craniotomy procedure in the last year. And then lastly, we required a nivolumab and ipilimumab exposure both before and after the stereotactic radiosurgery index date. This returned us 12 patients from 2 large US claims databases. So we reviewed these patient profiles, and on the screen you can see one of them here. The horizontal y-axis shows us time relative to the index date, which was stereotactic radiosurgery of the brain. 3.5 years ago, this patient had a melanoma diagnosis and a sentinel node biopsy. 4.5 months before this index date, their situation deteriorated. They had a cerebral hemorrhage, which likely then identified the secondary metastases in the brain, lungs, and GI system, and prompted the craniotomy for resecting a brain tumor. Shortly thereafter, this patient initiated ipilimumab nivolumab combination therapy, followed by nivolumab monotherapy. Interestingly, this patient took nivolumab monotherapy after their stereotactic radiosurgery, which was one of my options. This patient's clinical history looked pretty remarkably similar to mine, but with so few patients, we relaxed the prior craniotomy and SRS requirement to produce a cohort that still resembled the intent, but was of a larger sample size that could produce more reliable aggregate statistics. It was from this population that we created 2 exposure cohorts for use in a comparative population level effect estimation framework. There was the ipilimumab-nivolumab combination therapy cohort that was indexed at first exposure to Nivo with an IPI exposure observed between 7 days before and 7 days after the Nivo exposure. The Nivo monotherapy cohort, exposure cohort, was indexed at first exposure to nivolumab with no epi exposure observed between 7 days before and 7 days after the Nivo exposure. This returned us 25 and 35 patients respectively. We assessed the baseline characteristics of the IPI-Nivo and Nivo exposure cohorts in terms of index year-month, condition occurrences, procedure occurrences, drug exposures, all during the year before index. The idea is that if we were to see cohort similarity at baseline, it may allow us to make the cautious inference that any differences in procedure and condition occurrences during the year post-index may be attributable to the ipilimumab exposure and not observed confounders. So then we compared the 1 year post-exposure characteristics of the IPI-Nivo and Nivo cohorts in terms of observation time, condition, and procedure occurrences. And these conditions and procedures were intended to represent proxies for safety outcomes. And the observation time was meant to represent an extremely crude proxy for survival, since patients can exit the database at death. So here we see that on the x-axis, this shows covariate prevalence for the IPI-Nivo cohort, and on the y-axis, the same prevalences for the nivolumab monotherapy cohort. The left panel shows this information in the year before exposure, and the right panel shows this information in the year after. At baseline, we see that the conditions and procedures are evenly distributed about the diagonal, showing that there are few observed characteristic differences between these groups. Importantly, they were well balanced on baseline covariates that included cranial inflammation and hemorrhage and prior targeted therapies, which are both plausible confounders of the relationship between immunotherapy choice and subsequent cranial complications that I'm so concerned about. In the year forward, what we see is that the conditions and procedures were predominantly below the diagonal, indicating a greater prevalence in the IPI-Nivo cohort. We observed craniotomy procedures slightly more frequently in the IPI-Nivo cohort, but importantly, cerebral infarction and cerebral hemorrhage were approximately twice as common in the IPI-Nivo patients. Lastly, the nivolumab patients had longer post-exposure observation time, which might suggest an association with increased survival. This exercise is obviously subject to condition and procedure misclassification and residual confounding. But given the decision-related time constraint and that we observed similar results in 2 large data sources, and that the findings were aligned with a hypothesis from the literature, I felt that this was a reasonable piece of information to use to support this decision. This evidence obviously is not going to be good enough for a publication. It's definitely not going to JAMA, but it was an extremely useful evidence for this situation that I was faced with. So ultimately, I resumed Nivo monotherapy, and I'm still on it and feeling well. So far, my outcomes have been good. I've bucketed them as health, as in health. My energy and strength is increasing. I'm gaining weight, and I haven't had any subsequent neurosurgery, which makes me very happy. I can participate in most of the important areas of my life again, like with my family and my friends and my professional colleagues. I can horse around with my kids. I can see and enjoy my friends, and I'm back at work and finally going to start that doctoral program that I've been hoping to start for years. This journey was really made extraordinarily easier by a brilliant and dedicated oncologist and other care providers, the immense support from my family, friends, and colleagues, and it was this support that allowed me to focus completely on my health. And it was, in many ways, my initial distress that was total was replaced with a profound gratitude. I know that my journey isn't over, nor will it ever be, but it's been really improved by this exercise and this experience. This exercise in personalized real-world evidence generated at point of care was an interesting one. The real-world evidence was personalized in that it leveraged information from cohorts of patients designed to reflect me and the specific decision at hand. And it was point of care insofar as that we generated it over a 36-hour period between when the decision requirement became apparent and when treatment continuation had to happen. So really, OHDSI community, this was your tireless work in data standards and methodological research and open source development that facilitated it. So as sincerely as possible, I thank you endlessly. What I really hope you'll remember from this is less about me and more about this really special research enterprise, and specifically that OHDSI's mission is to generate reliable, actionable evidence for patients. But patients isn't some obscure, ambiguous them, but it's also very much for us, which includes you and me and our families, closest loved ones, and everyone else we know. But by speaking a little bit about myself, my intent's really to remind us that behind every single one of these hundreds of millions of patient IDs is another story like mine, full of every up and down you can imagine, and each story perfectly unique.
We lost Jamie way too soon, but I think he's going to continue to be an important inspiration for what we do as a community and why we do it. I know that several members of our community would like to share their reflections. I know Danny and Nigam are already lined up, but we'll stay on longer for anybody who'd like to share what you said, and if you want to raise your hand. But Danny, I'll turn it over to you to go first.
Very hard. Well, Jamie was from the beginning one of those students that you know you're going to be able to give very little to, and from whom you're going to learn a lot. Unfortunately, I had to learn things that I really didn't want to learn from him, like how to endure a condition like that and how to combine family, job, and his passion for his PhD with us. I think there are a couple of things that I really was keen to complete with Jamie that we really didn't get to do. One of them was the work that he was doing for his PhD, and I'm happy to say that I'm gonna make sure that happens. We have secured funding to fund a Jamie Weaver scholarship here at Oxford, and we're gonna get someone bright to finalize that work that he really wanted to see completed. And the other bit of work was the expansion of OMOP in Canada and the mission of OHDSI in Canada. And that's something, you know, I'm not going to give up on. And there's colleagues who are trying really hard to create an OHDSI node in Canada. I'm going to go there and support them, and I'm going to make sure that I continue his work. I'm pretty sure that I'll never be able to pay him back for everything he taught me, but yeah, as you say, it's very important that what he gave us continues, and I'm going to make sure of that as much as I can. Thank you.
Thank you, Danny. Nigam, can I turn it to you?
Sure. It's kind of hard to speak at this. The thing I'll share is the openness with which Jamie shared his journey is going to continue to inspire students, at least on our campus and hopefully others, for a very long time. In fact, this exact video we watched is something that is required viewing for about 70 students each year. And then the thing they have to answer is, what are you going to do to help Jamie? And that's it. Like, nothing that professors can say would inspire people more than watching a real person and then asking themselves, what are they going to do to make a difference? So that will continue to live, and I'm pretty happy about that.
Thank you, Nigam. Mitch, I see your hands up.
Hey, can you hear me?
Yep, we can hear you.
Great. I did just want to shout out another piece of scholarship by Jamie that I had the privilege of working with him on. He was just an important friend, mentor, and colleague to me. So he actually mentored me through my first study at Johnson & Johnson, which was looking at the comparative safety of abiraterone and enzalutamide in the space of metastatic castration-resistant prostate cancer. So just like a really high level on the scholarship, metastatic castration-resistant prostate cancer is an advanced stage of the disease. It's rare and it's hard to generate safety evidence about that space. Cardiovascular disorders are a major concern because abiraterone is prescribed concomitantly with prednisone, which carries a risk of cardiovascular disorders. But we did a large-scale comparative cohort study across the data network to compare the incidence of hospitalized heart failure, AMI, and stroke among patients who were taking abiraterone and prednisone compared to patients that were taking an alternative medication in the space, enzalutamide. And basically, thanks to Jamie's guidance and scholarship, we identified a substantial increased risk of hospitalization for heart failure among patients who were receiving abiraterone. And really just the high-level reflections I have, and it was one of the places where I learned many things from Jamie, but it sort of taught me how to navigate a complex corporate environment. And, if anybody knew Jamie, he had this deeply collaborative spirit, but also strong scientific convictions. And I think that's the thing, in some sense, I might take away from him the most. But at the same time, he taught me to interact with OHDSI's standard analytic packages and like the things he could do with those things. Like, he could do anything with it, opening those up and tweaking them. And yeah, it was incredible. But it was actually some of the earliest implementations of the objective study validity diagnostics, and he referenced it in the paper that you cited, Patrick, with his work on study validity diagnostics. But again, just I think in the substantive area, his passion for just the value of rigorous science and the impact that it can have on patients, and especially with this one, the impact it can have on patients who are experiencing sort of rare and complex disease that's not addressed by other evidence systems. But we'll deeply miss him, and I think most of us will just carry something that he taught us with us the rest of our careers.
Thank you, Mitch. Kristen?
Everyone. So some of you don't know me because I have been hiding for a few years. Jamie and I matriculated to Oxford together, and unfortunately, Danny has the worst luck, I think, with the October 2021 part-time student cohort. I also got very, very sick during my DPhil study and had the privilege of being alongside a scientist and a patient advocate and someone who gave me a lot of strength and courage to understand how to use real-world data to inform my own decision treatments, and also just a friend that could kind of bridge the world of translating science while feeling its impact every day. I suffered a stroke, so as Mitch just said, it's an outcome we see all the time in our studies. So if you're looking for patient impact, Jamie helped me kind of embody and feel confidence and return to my studies not once, but twice. So 3 months from today, I will defend my thesis in hopefully. And what I'm really most proud about is that I can cite his work. He had some incredible foundational papers that I can use inside of my own thesis. And so the best thing I can do is to raise his H index, even posthumously. But I am very, very grateful. And he was always very good at eviscerating us with really good feedback. And I will miss that very much. He was quite a good reviewer too. He prepared you well for being able to have the scrutiny of our scientific community. And I think we all benefit from that. All boats rose. And man, was he a patient human being with us who are not so good at coding our shiny apps. So I have to reiterate that it used to be the dark days back in 2018, and you all should be so grateful for all the GitHub commits and all of the things that Jamie did to make these much more scalable. And I know he spent many, many long hours listening to us say really stupid things, and he was very patient with us. So I will miss him very much.
Thank you, Kristen. Anybody else like to share a reflection? I know we're at the top of the hour, but all right. Asia?
Okay. It's really hard for me. We heard a lot about Jamie. I can't talk about his science. Everybody did a good job. Jamie and I taught a couple of courses together. And in addition, for him to be a real human being, he was such a great teacher and so dedicated. He really cared. And yeah, sorry. I really miss him.
Thank you, Asya. Ajit?
Yeah, I mean, he's such a sweet guy, and we worked together on a lot of projects at J&J when I was there, and I learned a lot from him. And just the human side, I mean, I just really look back so fondly of just time spent, talking to him about basketball, at the bar. I remember when we were talking a lot about the Sixers and the Raptors some years ago, and he really knew how to talk trash, but do so in a way that was just like you couldn't get mad at him. So he's just such a great person, great human being, and that's what I'll miss the most. I mean, obviously a stellar scientist, but just the human side, just a great human being.
Thank you, Ajit. Jenny Lane was not able to join the meeting, but she sent a message that she wanted to share. She said that I'm incredibly proud that I got the opportunity to work with and know Jamie. Getting those hydroxychloroquine studies papers done during the pandemic was a huge challenge, but to him it was always something they just took in stride. Daily, our COVID core crew would meet and drive forward what became practice-changing research. He was incredibly talented, humble, and funny, and so much cooler than me on top. I'll best remember him for the Barcelona Study-a-thon in 2020, those few months before the pandemic kicked off, coolly coding with a beer in hand and on the beach after hours. And I'll always be sad that I didn't get more time with him. All right. Well, I want to thank you all for joining us for this tribute. I hope that you'll continue to use Jamie's life and legacy and scientific contributions to continue to motivate and inspire the work we're doing as a community. Jamie is going to, we will all be impacted directly and indirectly in his work, and I really do think that it is probably the best tribute we could pay to him is to continue and to advance the science that he was so passionate for, to improve the lives of patients around the world. And I hope that you'll join me and continue to be inspired by what Jamie offered us, and to continue to honor his legacy by continuing in this work. Thank you all for joining today, and we'll see you next week. Bye, everyone.